Hey everybody, welcome back to The Pathway. Taylor Henrick here. I'm here with my colleagues Sarang Patel and Michael Hunter. I just want to provide a quick warning that there's going to be some sensitive information that we're going to talk about today. Our topic centers around suicide prevention and suicide awareness, as this month is Suicide Awareness Month. We hope that as you join us today, we're able to go over some information that could be helpful for you. Stick with us today. Sarang's on his second cup of coffee, so that's always a good start to the day.
It's a tough topic, man.
It is a tough topic. I guess leading into this one's not going to be the easiest to talk about, but it's a good thing to talk about. We know that September is Suicide Awareness Month, and not so much something to celebrate, but something to memorialize, something for us to be cognizant of and maybe share some of our insights into this topic overall. Whether you have personal experience with someone who's committed suicide, know somebody who has unfortunately taken their own life, or just become aware of somebody struggling in their own right, it's something that us in the mental health field will deal with on an almost regular, if not semi-regular basis. If you're lucky enough in the mental health field or in your own personal life to not be affected personally by suicide, I would say that those are rare cases these days. Speaking as a provider, I lost some individuals myself. Just sharing this not to be shining the light on me, but I lost individuals during the pandemic. I hadn't prior to the pandemic as a prescriber or provider. And during the pandemic, I did lose individuals. And I'll never forget their names. I'll never forget these individuals myself and the effect or the imprint that they left on me as a prescriber. And again, this isn't a soap story for me, but I will never forget those individuals. I'll never forget their stories, their family members, et cetera. It's not something that you can move on from,
right.
You know?
When it comes to preventing suicide, I think that it's one of the things that I've learned is not to whisper about it. So I'm glad that there's a Suicide Awareness Month, because historically we would say so-and-so committed suicide. But, we really need to talk about it directly.
That's a good point.
I even think what I've learned over the years is that even if someone, if I'm concerned, are they thinking about it, I don't even whisper it to them anymore. Now it's a very direct question. Are you thinking about killing yourself? Are you thinking about harming yourself? Are you thinking about harming somebody else? And you get a real answer back. If you tiptoe around it, then they seem to think that it's a taboo conversation and are going to give you the answer they think you want to hear, as opposed to, a real answer. And we know how still unpredictable it is, so it's important to try everything we can to prevent it.
Absolutely. As a prescriber or a provider, I always like to comment on, I always applaud my patients or in appointments if they share with me that they're having suicidal thoughts or passive thoughts of not wanting to be here. Often it's, just one scenario is a lot of times people say, well, I thought about driving into traffic. And I always tell them, hey, I'm glad you told me. Like, I really appreciate it. I'm glad you opened up to me rather than keeping that inside. I hope that you telling me gives you some small solace because it makes me feel better. The clients, in my experience, that I get worried about are the ones that won't talk about it. It's the individuals who are struggling in this internal battle or strife with depression and are not willing to say anything. And then all of a sudden, I'm getting a hospital discharge paperwork on somebody who was at the hospital and tried to overdose, and I had no idea.
It's always one where you least expect it, right?
Mm-hmm.
So
Truly.
to piggyback off what you were saying earlier is, I don't know if it's it's not a boastful thing either on my end, but I had, unfortunately, more patients that I lost to suicide pre-COVID. During COVID, there's I think a couple of prongs here. During COVID, mental health has definitely increased for sure. We saw that, right? So that was there for sure. So the amount of patients we've seen has increased. Maybe the amount of patients that have suicidal thought has increased as well. However, I feel like when they gave us telemedicine during COVID, I was able to help save more people because I could follow up with them every couple of days easier than them having to pre-COVID come in every month, every week. So I feel like I can name people, unfortunately, that before COVID, I still know their names that I've lost to suicide. I can't name any during COVID. And now, because like we've been able to follow them so frequently, which has been great, they get into therapists a lot easier. You know, at the CMH setting, in particular, for sure, telehealth has like saved them. Audio only saves a ton of people.
Correct.
And you know, they said quality of care. It's better that care than no care.
100%.
Yeah. I think that you're absolutely right. Being able to get that access to care quicker is the key, because it's in that middle of the night. It's in that when it's a Saturday. It's when that off time happens that they need you. And if they can't get you, or like you said, I got to get on a bus, I got to get an Uber, I got to get somebody to drive me, I got to get it.
Yeah.
They're not going to do it.
No.
You know, they're not thinking, oh, let me go save my life. They're going to say, can I talk to you right now?
Yeah.
For the persistently depressed or the dysthymic, all it takes is a small trigger.
Yeah.
We've all seen it. All it takes is a bad breakup, a loss of a family member. I'm not saying these are small triggers. I'm giving examples. A loss of a pet, a loss of a job. It doesn't take much of a catalyst for someone who's already in a bad place. And that's the scary part. And that's where, you know, I've been utilizing recently, I've really been pushing 988. The 988 hotline has been a really good advent and something that I advocate for, and I share very, very openly with my clients. Hey, give this a call. This is here for this purpose. If you're ever at a point where you can't reach me, my staff aren't available, it's after hours, it's a time where you know you're not going to be able to reach out to your support system, call. They have people ready to go.
Yeah. There's some apps out there tied to 988 too. This is cool to prevent suicide. That will help too. And they're national now too. So I think there's a lot of resources if we can continue to point people towards them and not be afraid to.
Like NAMI mediated stuff, like some of that, or
No, NAMI. I don't think NAMI has an actual app, but they probably endorse and support some of the apps.
Okay.
But I went to a health tech conference in Austin, Texas, and they were highlighting these suicide prevention apps that were going to partner with 988. Yeah.
Cool.
It's still allow the person
That's
to
pretty
be
sweet.
anonymous, and it basically ends up being a text conversation.
that's a really good idea.
Yeah.
You know, with the suicidal thought thing, I know we talk about, like, obviously from a patient standpoint, what we do, right? But from a prescriber standpoint and therapist and anyone, mental health, case management, anything, is we just talked about this last week or 2 weeks ago. We sometimes, psychiatry, get numb to someone having suicidal thoughts. Like, it's like, oh yeah, they're transiently suicidal. Like, we've seen it before. This person's been there. But the risks are still super high. So I'm talking about documentation here and just in general, right? When someone has suicidal thoughts, we should, and I don't think we do enough of it, but follow up more frequent.
Yeah.
It's not
Agreed.
just only when they need to be hospitalized, you follow up them earlier. It's that, hey, you have a higher risk than normal. Maybe you're transiently suicidal, or you were in the last 6 months. You should be following up every 2 weeks.
Yeah. Instead of just thinking it's the status quo.
The status quo.
Yeah.
Yeah. I've had like 5 people like that. Your risk of suicide are moderate. No, their risks are high. Treat them individually. Look at their past history and experience. You know, finances, job, healthcare, access to healthcare, all this kind of stuff, health issues, and see, do they really need to be followed up more frequently or not? And they should.
And speak on your own experience. What have you seen when you've done that personally?
Well, I think it goes back to that, what I was mentioning earlier, that post-COVID, I feel like suicide completion, right? I guess is the best word to use it, right? Has been less than it was before because you're able to follow up them more frequently. So if I have someone who has suicidal thoughts, I will see them at the maximum in 2 weeks. Maximum.
Same.
But if someone has new suicidal thoughts, I will see them again in 2 days. Unless I have to send them to the hospital, I will see them in 2 days. Because that itself sometimes gives them enough reassurance at that point. It doesn't mean you're going to make a med change. It doesn't mean they can't see their therapist the next day or the same day. It's just you should touch base to see, do you need anything else urgently at the time? It gives them a lot of reassurance. Okay, my sleep, my whatever it is, the new med change you're using, or there could be a new med change you're going to do, and it gives them that reassurance there. I think it saves them. But we then say, well, will insurance cover the appointment? Is it too early to do it? What's right for that patient right there in front of you? And you say, yeah, see you in 2 days. Just a cardiologist. Like, if you want your EKG was jacked up and your troponin levels are elevated, they're not going to be like, I'll see you again next week.
Right. They're sending you to the ER.
Yeah.
Yeah, right.
Yeah.
Or, hey, your EKG's off, your tropes are normal, right? Your blood work looks fine. Your EKG's off. I'll see you again in a couple of days. That reassurance is great. You want that.
I appreciate that approach. And I think seeing people more often, as you and I have advocated for time and time again, makes a monumental difference. There's no doubt about it that letting someone know you care enough to say, hey, I might be busy on Thursday, but I'm going to fit you in. And it's not about giving that credence, but just showing that you care. I want to follow up. I need you to know that I'm going to call you. I need you to know that you need to be on telly with me, or you need to come to the office because I care about you. I want to make sure you're doing better Are you the same or are you worse? Do we need to do some sort of an intervention to help you? Because where you're at right now is not good enough.
Right.
You are in a place where I'm not comfortable with you feeling the way you feel.
Yeah, I guess I have a little bit of a problem too. And some providers say, well, I don't have enough time or my schedule is jam packed. That appointment for someone who has suicidal thoughts does not have to be a lengthy appointment. It's sometimes just a check-in. You're not changing medication. Yeah,
showing that you care, like you said.
that's all it is. It could be a 5-minute appointment, but you're showing that they care. You're just making sure, do they need to go to the hospital? What's the plan? What's the situation at home? Spouse, parent have to go to work. What's the issue that changes? So I think that you should always, even if you have a jam-packed schedule, be able to fit them in.
Absolutely. What other prevention steps can we take? Being in the field, all three of us being in mental health and it being a significant part of our lives, what other measures can we take, do you think, to help suicide prevention within our industry or outside of our industry?
I think one of the things is to make sure that we really listen to people, especially the younger they are, because if you think about peer pressures and stuff like that, and encourage them to say something if they suspect that they have a friend or peer or a sibling that they believe may do self-harm, saying something and giving them the freedom to do so. Don't make them think, oh, this is a bad thing if I quote unquote tell on so-and-so, because you could be saving that person's life in the longest run. And then making sure that people realize they have value. Somehow we have to make sure we show you have value. You know, I may not remember your name. I may not remember a whole lot of things about our interaction, but I will remember if I thought you cared about me or not.
Right.
That won't leave me. You know, if you treated me like I was less than, that'll stay with me. If you treated me like I was a person, that's going to stay with me. And I think those are some of the subtle opportunities we have, because you never know what somebody is going through on any given day. And they can present very, very well. And you don't know.
Well put. I really appreciate that. I want to second the thought of see something, say something.
Yeah.
You know, it's kind of a cliche saying. It applies to different avenues than this. But if someone seems off or you're seeing traits that could be indicative of, you know, any kind of self-harming gesture or say something.
Yeah.
Intervene. You obviously care enough about this person to notice.
Right.
Bring it up. You know, don't let it get to the point where people are writing letters to their family members. Don't let it get to the point where they're planning or doing this, that, and the other. We have to head it off way sooner than that. We have to. Any ideas on prevention? I really like what Michael said. If not, that's okay. The other side of this conversation, and I think the other part where it's important for us to mention, is how can we raise awareness? That's the other part. Prevention is one step. How can we raise awareness amongst the population? Are there educational opportunities? Are there things that we can do? Are there platforms we can use to make the general population a little bit more aware of suicide as a topic?
For me, I like to be creative and think outside the box. I think that how we educate people is one thing. And I think that a lot of times our education is more for the person who is not suicidal. But for the person who is suicidal, again, figuring out a way to show them that life is worth living. Like, no matter how bad it is, it's not bad enough to die.
Yeah.
Because if you die, it won't get better here. Now, what happens afterwards, you can deal with that. But it's not bad enough to die. So how do we get that message across? And I think some of that is just really, really pounding into each other that each life has this value and not sticking our head in the sand. One example I'll give is I have a family member who was very, very active, normal childhood, the whole nine. And I believe this person had a mental health break right after graduating high school, like literally the summer of graduating high school, finishing high school. And when he was going through what he was going through, you know, different family members of mine were hiding it from me. And I'm the professional in the bunch. And they were hiding it from me until 2 years later, I find out he had been hospitalized. He had moved out of state back with his mom, hospitalized a number of times psychiatrically. And so I call her and I'm like, hey, how's he doing? And I understand this and this. And she says to me, oh, that boy needs Jesus. He just needs to be in church. I'm like, no, he may need Jesus, but he also needs some Ativan or Adderall or some Cymbalta, something, not just Jesus. If he had a headache, would you tell him to go pray? No, you would give him some Tylenol. Right. So let's let Jesus bless the Tylenol. Mm-hmm. You know,
That's a good one. I like that one. I like that one a lot.
Bless this Tylenol.
Yeah, exactly. So I
like
think
that
that those kind of opportunities are where we miss the person that's gonna complete suicide, is because we are so stereotypical. We are so blinded and so set in our ways. We forget this person is really hurting here. How do we fix the hurt?
Great point. Stigma, right?
Oh, it's big time.
Embarrassment, not wanting to fess up or acknowledge what one might be going through.
Yes.
And that is an oversimplification. And we never blame our family, right? It's
Right,
like, hey,
exactly.
they may be trying to help in the way they know how. That might be
Yes.
what they're comfortable with. Hey, prayer has helped me, so I'm going to have you pray.
Yes.
But for an individual who's struggling or who might be going through it, man, there are resources out there. There are more things that we can do, whether it is religious, environmental, medication-based, support-based. There's so many different things that we could do to help intervene with that individual in those instances.
Yeah. And we have to. We got to take advantage of it. We can't just sit back and be like, oh, it'll heal itself. No. But I like what you said, that they're doing the best that they know how. So again, that prevention information, that education for the person that's not suicidal has value, but we still can't forget the other person that really is hurting, that's really trying to get through this. Like, how do I stop myself from having these thoughts? How do I stop myself from, like, what's my new motivation? It can't be just because you told me to.
Yeah.
It has to be something deeper than that.
The other side of the coin is, I'm sure Sarang's been there too, but I have examples of where I'm treating patients who are survivors of family members who have committed suicide. And the cases, again, just ring so true and are so memorable. The survivor's guilt, the long-lasting effect on the family and the immediate environment, the support system, the community, is just, it echoes for forever. It's just the permanency of these types of actions. It's, I don't know how to describe it. It chokes me up thinking about some of the people that I've had to speak with and that I've had to have those difficult appointments right after with family members. It leaves a lasting impression on you. And it's a lot. It's a lot for those people who are left behind. I never lose sight of this one decision affected so many people and made their lives so drastically different. It's just a firm reminder for anybody who listens to us, or anybody who this impacts or touches. Like, it's not about coming into Pure. It's not about going to Team Wellness Center. It's get help. Call 988. Take a step to help yourself. Take a step to help somebody else. If you see somebody struggling, spend 5 extra minutes with them.
Yeah.
Give them a call. Those types of little effects. Hey, how you doing, man? Sending a text message can make a difference, right?
Right.
It's just, man, never.
I think you said something that just reminded me when I talk about really getting to the person who is having those thoughts. The ripple effect is very effective. There's an agency called The Ripple Effect. It's a nonprofit because, and when I met the gentleman who started it, was really profound. He had attempted suicide, and he has a unique story in that he was either the last or the second to the last person that tried to complete suicide by jumping off the Golden Gate Bridge in California. And because of that him or the last person, they had a campaign to put
netting. I remember this. Yeah.
So they put all the nets around the bridge, and because out of however many in the world that attempted, only like 6 or 7 survived, and he was one of them. And so he travels the country now, actually the world now, with his story about trying to encourage people not to try and complete suicide. And it's called The Ripple Effect because he shows you, like, if you drop this pebble in the water here and you see all the rings and it ripples out. He said, that's you if you commit suicide. Yeah. Now, here's all the lives you're going to impact by your one decision. And
it's crazy.
Yeah, it's really crazy. But it was effective. He has countless people that have told him how his story and that ideology has helped them, not go through with it.
Right.
Yeah.
That's crazy. I think you said earlier, what other aspects could you make it more aware? I don't want to say earlier because I thought maybe it's only for myself, but I'm a data-driven guy, but also a visual person. So the ripple thing made me think about that, where it's like, I think especially in a young population, you need to show them, it's not just stats, but like when you talk about programs, we talk about for sure too. They say, hey, 4 out of 5 people, you show the visual aid, like you show people, not to say, hey, like it's to shine light on it, to see how prevalent it actually is, how prevalent it is in this modern world compared to other countries even as well. You want to show that data or show the ripple effect and kind of give these visual aids to people to kind of see, okay, yeah, it does make the difference. I don't think we do enough of that unless you're at a program and you're learning, right? But what general public is seeing that?
Yeah. Yeah. I wonder if that sounds like a really good resource. I would actually be really curious about bringing him locally. It might be good for providers, prescribers, counselors, therapists to hear from him.
Yeah.
And just to remind us, like you said, to not become numb to it or it's so often. I feel like every time I'm seeing clients, somebody mentions that they were passively or actively suicidal. It becomes second nature in a scary way. Like we don't normalize it. It's not a normalizable thing, but we're so used to hearing it in mental health. I could admit that maybe I'm a little bit numb to it. I don't get as fearful if I know the individual well enough, and that's scary.
Yeah.
I should be doing everything I can to help them with that. And it's not out of me feeling overly comfortable with them or thinking they're good enough, but you just get used to it.
Right.
Yeah.
There's still a stigma behind it, right? Complete big stigma. I always say the example I give you is sports. I didn't know, September, when it's sports season, we never talk about it. There's no big NFL, NBA, whatever it is, that's having a big suicide prevention month.
Right. But there should be.
There's cancer, and then it's great for everything else. Great. Yes.
I'll tell you what comes to mind for me big time in September are my daughters. So I have a daughter that's a new teenager, and I have a daughter that's a preteen. And I think about, okay, when they go to school and what's the experiences that they can be influenced by from peer pressures and, depression and, am I going to be happy and popular enough? Am I going to be smart enough? Am I going to be accepted? And all those kind of things. And I don't want them harboring self-harm thoughts. And so I'm trying to figure out, okay, how do I make sure that they have a clear path to expressing that if that's how they feel so that they can get that help, and not being apprehensive and not spooking them, by any means. But I think about that actively.
Absolutely. And I think personalizing it actually helps.
Yeah.
When we extrapolate it onto ourselves, then you're like, okay, what steps can I take to make sure? And those open lines of communication, commending you as a father. I mean, those are not easy conversations to have with a preteen and a teen. But at the end of the day, you probably feel a little bit better knowing that you had those conversations and knowing that they can come to dad if they're not feeling well.
Yeah.
I mean, what else could you ask for?
That you have to. I think in this day and age, if you don't, we're going to be at too many premature funerals.
Yeah. Proactive.
You're exactly right. And I think Sarang commented on it that age range for taking one's own life, where is it going? It's
lower and lower.
It's lower and lower.
Yeah.
You hear about kids who are in their preteen years, being preteens or right around that arguably, 9 to 12, having thoughts of not wanting to be here or making mentions of not wanting to be here, acts of not wanting to be here.
Right.
Ending up in hospitals at that age range. Scary stuff.
It's very scary.
It's accelerating in the wrong direction. Where we can say that the pandemic was the silver lining of it, we always say, has been increased mental health awareness. Suicide is going the wrong direction. It is.
And with the ripple effect, like I would think back when I think about my own experience too. I didn't know the vocabulary for mental illness, as I said on the previous show. But once I learned it and started doing some self-reflection, I'm like, okay, when was I ever really impacted by mental health or trauma? And then I think the first thing that comes to my mind is my stepdad committed suicide. And I'm like, dude, he sure did, didn't he? Yeah, he did. And then what effect did that have on me consciously and subconsciously? And being able to say to my daughters, this is real. It can happen. It can happen to quote unquote us because it did happen to us. And now here's how real it is. This is a person you've never met.
Right.
And the reason you never met him is because he did that. But if he hadn't have done that, this is a person that, would have been your step granddad, you know, for
could have been a staple in their life.
Yeah.
Correct.
Yeah. Would have had an impact on them.
Exactly.
Would have been somebody that they could have made him happy.
Right.
He could have brought joy to their life.
Both ways.
Yeah.
Right. Yeah.
And I think the more we point that out and the more we remind people of the impact that they have, even in our conversations, I'm like, hey, I care about you. Like, I've really enjoyed getting to know you the last couple of years. Like, if you weren't here for our appointments, I would miss you.
Right.
I don't care if it sounds feeble. I don't care if it sounds personal. If it helps that person feel a little bit better to know I at least think about them, I don't know. Maybe it helps. Maybe it doesn't. But I'm still going to say it.
Yeah.
So I guess there's steps that we can all take. There are steps towards prevention. None of us are experts.
Yeah.
But we all have experience, firsthand or secondary, with these types of things.
Let me ask this question.
Yeah.
From your training as a prescriber, in the training process, academically or otherwise, how do you remember it being taught to be sensitive about somebody potentially wanting to do self-harm?
I don't think you're taught to be sensitive. And that's the hardest part, right? I think a lot of this stuff comes down to, I always bring up frequency of appointments, but I think what you were just mentioning too, how you like talk to a patient about that, how you feel, hey, I missed you, or hey, thanks for being here. When you see a patient repetitively, right? Obviously, if I'm just prescribing medication, fine, it could be quick. But talking about anything, dog, family, pet, whatever it is, job, finances, you get to know that person. So if I see you once a month and you're stable, totally cool, but I see you 12 times a year, over the course of a couple of years, I have seen you a ton.
Right.
You're like a friend now.
We've talked a lot. Yeah,
talked a lot.
Exactly.
Yeah.
Even if it's 10-minute conversation, sometimes it's more than like old past acquaintances. You know what I mean?
Yeah.
It's a lot. Or people at your office sometimes more than that. So you kind of say, okay, well, you build that relationship with them, and I think that helps you tremendously. But in school, I don't know if you had a question there, but in school, I don't think we're necessarily taught how to do that. And that's the hardest part. I always bring up, I think we talked about this before, is empathy behind it. The empathy, I think psychiatry was lost for a long time. I think patients felt it. We hear about stories from it. Scripts being ready when you came to the office. Prescribers don't know what the heck's going on. Therapists don't know what's going on. You know, that relationship, that empathy's lost. You either have to just meet the patient where they're at. Sometimes I don't have the answer. We don't have all the answers for you. But we're here to help you get through it.
Yeah.
And if you just provide a little bit of empathy, like you said, right? Be there for that person, meet them where they're at. I think that is where it gets them across the finish line to be safe. But I don't know if we're really taught how to do that. You're taught like, hey, resources and directing to therapy and do this medication plan and follow this protocol. But that's like just textbook stuff.
I agree. I don't think we're really educated on it. If anything, I think we're educated how to document appropriately for CYA.
Yeah.
And I mean that like
Literally.
seriously.
Yeah.
We are documented how to maintain and manage throughout losing a patient. Like, if that's not ass backwards, I don't know what is.
Yeah.
Like, we need to be there to be able to prevent it or do what we can to take those appropriate steps and know consciously and wholeheartedly that we did everything we could to help. And unfortunately, we still had a negative outcome. You know, it's not about just trying to make yourself on paper look safe when you lose a patient.
Yeah, that's how we're taught.
Right.
Yeah.
It's always CIA.
Wow. And I can tell from your from knowing you guys both that you both care. And it's genuine care, and I know that comes across to a patient population. So kudos to both of you.
Thank you. You as well. Well, I appreciate you both. This was a fun one. Very difficult topic. And I mean fun in that it's congenial, and I always learn whenever I'm speaking with both of you. You guys are awesome, and you have such good experiences and perspectives to share. And I just want to say it's always a pleasure, Michael. It's always nice going into things, and we've been blessed to have you here today with us for this one.
Hey, so have I. Thank you guys.
Thank you.